of you all are writing in November. But for the most part, you're writing in May, so your Saturdays ought to have become a day for work and work only. You're 2 months away. That is if you want to be excellent. If you want to just pass, I guess you probably could chill out a little bit. I'm not one to talk because I used to be partying right through on my Saturdays, even close to exams. Um, I wouldn't recommend your party, but ensure to prioritize your mental health and take breaks and stuff, right? But you don't want to be wasting time at this point. Every day is a chance to learn something and to excel in your exams. So despite that, you didn't have to be here. And so thank you for coming out on the Saturday, which is very admirable. Again, I want to say compliments to all of you on the homework. I really was impressed with the fact that you'll actually do the homework, right? And then get back to me with it and then have questions and some of you even like routine explanations on the papers and stuff. And I just want to reiterate that practicing on your own, studying by yourself, on your own, in groups, what have you. But once you're learning outside of our classes and consolidating information, you are definitely on the right course, right? Definitely on your way to excellence rather than just success. Um, so today we'll be doing general surgery. I don't have homework for gen surg, right? So that's one thing. The reason being, yes, MCQs are going to help you as they usually and always will for every subdiscipline. Um, the thing about surgery is a pro and a con. I guess we could start off with the con. The con is that they hardly ever repeat questions or general patterns or themes like they do for medicine, right? Of course, things will seem similar, but they're not as clear-cut pattern recognition. It's not as easy to predict exactly what they're going to ask you for surgery. So as a con, the pro is that usually general surgery is one of those subdisciplines where your content suffices, where your general knowledge suffices. Right? There will be questions that require critical thinking and decision making for sure. Um, but out of the 60, at least 40 to 45 will be strictly just pure knowledge, fact-based questions, right? So that's a plus in that once you know all your content well, it increases your chances of passing. Rather than medicine, even if you know the whole of myocardial infarction or the whole of myasthenia gravis or whatever topic, even if you know the content well, based on how the question is asked, it might still be more difficult to answer, even if you had studied the entire topic. It doesn't usually work like that for surgery. Usually, if you know the whole of breast, you'll be able to answer 90% of the breast questions. And so for that reason, I do have questions here, it's not many, but I focus primarily on teaching the topic itself, right? And I try to go in as much detail as possible. So it's a little bit of a different approach, because most of the class will just be teaching, and we'll just start off answering about, I think it's 9 questions I have on breast, and then I'll teach, and then we'll just go back to the 9 questions, right? So that's one little difference there. Um, I did tell you all I would advise on how you should approach. This is studying the things like medicine and therapeutics and surgical specialties as well, right? So for those of us who might be a little bit struggling or a little bit weaker in some subdisciplines, my advice and how I approached the exam, and it worked out in my favor, was obviously I cannot learn everything. It's obvious, right? Um, unless you're some super genius or something. So you have to prioritize your learning. So where general surgery is concerned, I'll give you an example. For me, I was very good at general surgery. But then the other specialties, which came in our surgery paper, opthal, ortho, ANS, ENT, I was a little bit weaker in them. So my approach, and I recommend this to you, is the two that I was strongest in was, well, actually know opthal pretty well, right? And then I had known ortho okay enough, and then ANS, and well, I still know nothing about ENT, right? But my approach was I knew surgery, so I learned surgery very well. Then the other two that I was strongest in, that is optal and ortho, I learned those two very well. So because I had learned those three out of the five subdisciplines very well, and I would cover about 80% of the paper, I had room now the last 2 days before exam to just cram in what I could about the subdisciplines I was weaker in or that I didn't know well. I knew honest enough to synthesize good answers, but definitely ENT had to take the backseat for me, right? I am terrible at ENT. Um, the neck I don't like anything about it. So for me, I sacrificed ENT, but I did the other four specialties to the best of my ability. So my recommendation to you is not to fluster yourself too much because you cannot learn everything. So prioritize what your strengths are. That will get you the pass. And then after that, what your second strengths are. And when it comes down to passing the exams, your weakest areas, make sure that your weakest areas are a minority or it's just one or two subdisciplines that you're weak in. So that when push comes to shove, the day before your exam, you're just gonna cram in what you could about this subspecialty, right? Now that is not the best thing to do, obviously. You want to know everything, but it's impossible to know everything for your exams. So the same goes for medicine. I was very good at internal medicine. I was good at psychiatry. And well, pediatrics is a big chunk, so I tried to get good at pediatrics. So I am peds and psych. I would have learned very well family med. Well, capo smoke my pipe because I didn't know nothing about them statistics. I went in there and guessed that. And public health, well, again, kind of guess, right? So you want to prioritize your learning, prioritize your studies to get you the best mark. Okay, so every sub-discipline is different for everybody. Ideally, you would want to know everything, but if push comes to shove, make sure you know what you know very well and let that be a majority of what you're studying. Okay, so the things that are a minority, ENT, public health, family med, so on, you could kind of leave that to cram if it is you function that way, right? So that is one way to approach your preparation for exams, because exam preparation is very different to actually studying, and then exams and everything is very different to clinical medicine. At this point, you all just want to excel in your exams, right? When you become doctors, you'll see how different everything is. It's not theoretical at all, actually, right? Well, I in medicine, so I use a lot of my theory, but many of the subspecialties, even in medicine, it's very practical and different things apply in different places, right? So that's about the approach to surgery. I think most of you all are here, so we'll start in 2 minutes. Next thing is, uh, how am I going to validate myself teaching surgery? Because I have to give myself some sort of validity to say, hey, I am studying I work in internal medicine, going to specialize in internal medicine. What the hell I do in teaching general surgery, right? Um, I didn't even get a distinction in general surgery actually, which was very surprising to me, right? But they marked surgery very hard. I got 74 and a distinction of 75. So I got high honors. But that's not the reason why. The reason why is because I actually do know well, at that point, I don't know it as well now. But as a student, I knew general surgery content very well. Um, I got A's, A plus, blah, blah, blah. And so I knew the content very, 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 very well. Another reason why is because I had the great privilege, the reason also why I knew surgery and why I'm teaching it now, I had the great privilege of being on Dr. Ravi Miraj's team for year 4, year 5, and then I was his intern, right? For my foreign students, my regional students, non-Trinidadian, Dr. Ravi Miraj is the head of the clinical surgical sciences at UE. Fantastic, exceptional surgeon, but also a fantastic teacher with a passion for academia. So it was never easy being on his team. For those of you who might experience good old Ravi, you will know what these surgeons can be like and you'll know what Ravi is like. But we grew very, very close. And he actually recommended me to do surgery and they wanted me to do surgery, blah, blah, blah. Things happened and I decided to do medicine. But I was exposed to so much of his teachings that I knew surgery very well and I recognized what UE now likes to test because guess who sets the paper, right? Now I think Jamaica is setting this paper, but there is this book. So can I see in the chat how many of you have access to Dr. Ravi Miraj's book? That is the textbook of surgery for medical students. Great. So once you all have that book, it is safe to say that not everything, but a majority of your questions will come from that book and it's based on that book. Now, I have not had a chance to read that book as yet because I only got the book like, yeah, I'll send it in a group after. Oh, I also have to send the guide. I'll send it in a group afterwards. See, I'll send it in a group now. Give me a second. Yeah, I haven't gotten a chance to read the book. So if in my teachings you find something contrary to what the book has, let me know. And I can call Mr. Miraj myself and see what the answer might be, right? Because I'm not a surgeon and I haven't done surgery in quite some time, but my lectures are pretty okay and comprehensive. I don't know like what's the updated things, and then it's not just Mr. Ravi, it's all of the surgeons, even the gynecologist, Prof. Bassa, all of these shutters who contributed to this book. So is the book for the Caribbean, right? So I suppose that most of your questions will come based on this resource. So if it's anything you're studying from, it ought to be this book, which is sending to the group now. And I will send my breast guide. So this was actually breast and trauma the first time I did it around, but I decided to separate trauma because breast is a big topic, right? So So the guide sent, so you all could have that there. The guide is pretty well done, and the book is sending now, right? So, without further ado, let's begin. I have a full class today, nice. I know some of you like share screen with each other and stuff, but I like to see the numbers, it looks good. Why am I here? Also, I have never, usually like in person, when I teach my students on the wards and I draw, right? Because I'm in medicine, so I have medicine students and I draw. I've never actually drawn to teach surgery. I mean, you all know I can't draw on my handwriting, it's terrible, but at least it drives home the point sometimes. So I don't know how much of that I'll be doing today, but we'll see how it goes. This is our first. I do have my stencil and pen and stuff. So we would probably give it a go in between, right? Little concepts and things to try and explain. All right, cool. Let's see. Sarah Wilson. Sarah, there.
Hi, Doc.
Hey, what's up? You see any
Hi.
screen?
Yeah.
Right, cool. So, guys, I have favorites. That's a joke. But I knew I know like Serafina, Sarah, Verana. A few of them I know before, so that's why I call because I know they're comfortable talking to me, and some of you all might be a little more shy, right? So that's why I call them. So, good. So we see the screen. So we will answer the questions, and then we will teach. And we'll try to finish breast again, no later than half 8. It's one topic, but it's a humongous topic. So we'll try not to go beyond half 8 today, right? So you'll notice I don't have a border on these questions because some of these questions came from a textbook. I don't want to plagiarize and say it's mine. But it's a textbook that MBBS tends to use. So yeah, let's answer the questions, right? So number one, all the answers to number one in the chat, please. Okay. All right. Cool. Good. Number two, all the answers to number two in the chat, please. All the answers to number two in the chat, please. right? I've seen different answers. I've seen B's and A's. Let me get about 4 or 5 more answers now. This is an important concept. Good, good. So we clarify that. A's and B's. Nice. Number 3. Answers to number 3 in the chat, please. Answers to number 3 in the chat, please. Good, good, good. Thanks. Number 4. Answers to number, excuse me, answers to number 4 in the chat, please. Answers to number 4 in the chat, please. I think I have another option, sorry. Yeah. Answers to number 4. Number 5. Answers to number 5 in the chat, please. Answers to number 5 in the chat. Sorry, yeah. Sorry. Yeah, answers to number 5 in the chat, please. Zoom in a little bit more. Good. Nice. Number 6. Answers to number 6, please. Answers to number 6. Yes, let's get as many answers to this question as possible, right? Because we're already seeing the discrepancies between the answers. So I want you to type it in the chat. When you type it in the chat, if you get it right, you remember. If you get it wrong, you remember even more, right? So okay, right. Number 7. Number 7. Answers to number 7 in the chat, please. Number 7. Cool. Number 8. Answers to number 8 in the chat, please. Answers to number 8 in the chat, please. Cool. And the last question, breast would be number 9. Answers to number 9 in the chat, please. Cool. Right. Thank you so much, everyone, for your participation. I always tremendously appreciate it. How to get this thing here. Right. Y'all are fantastic. We do have concepts to clarify, and that excites me. I like when you all unanimously get things wrong. I feel like, oh, look how cute. They're so confidently getting it wrong. So that is fantastic. Thanks for the answers, guys. We would go on to teach now. Oh, sorry, my Zoom thing is not moving out of the way. Thing here. Okay, got it. Right. Cool. Right. Yes. Y'all seeing the screen, right? Seeing the guide? Okay, great. Thanks, Alicia. Right. Yes, we're seeing the guide, Doc. We're ready to go. All right, cool. So, good afternoon, everyone. Welcome to our first class on general surgery. Breast disease and breast cancer is an extremely important topic to know for your exams and even for real life, right? It's one of the most common cancers you'll encounter and one of the most common causes of cancer death that you'll encounter also, right? So the leading cause of death due to cancer worldwide is lung cancer, but second in women is breast and second in men is prostate, with colon being third in both parties, right? So the breast cancer is extremely important to know. All right, so I'm gonna try to deliver this information in a high yield manner that is likely to come for your exam. So as per usual, everything that I say is critically important, right? In between, I'll be trying to see if I could do some drawing or something to help you remember stuff. But for the most part, we'll use the guide to, well, guide us, right? So, one of the most commonly asked questions on breast cancer is as simple as it is, the risk factors for breast cancer. All right? Now, breast cancer is estrogen dependent. What that means is patients with high levels of estrogen and high levels of estrogen exposure would have an increased risk of breast cancer. That's why women are at a greater risk of breast cancer than men by far. But yes, some men do get breast cancer. Very, very few, and of course, extremely rare. So, Sydney is now joining us, right? Cool. So, how they bring this question in terms of the increased estrogen exposure is just how they bring it in obstetrics and gynae. That is it early menarche, late menopause, yada, yada, yada. So how you remember this and you don't let it trick you, and I'm pleased that most of you all would have gotten the answer correct. You think about the number of menstrual cycles that a woman was exposed to. So the higher amount of menstrual cycles, the more periods that she had, is the increased estrogen exposure that she had, and therefore it increases her risk. So early menarche, that's early start, first period. Late menopause, that is a later age of seeing her last period. Nulliparity, that is never getting pregnant and seeing periods all of her life. The first full-term pregnancy, advanced maternal age, that means she gets pregnant later and has had more periods. And if she, of course, is on hormonal replacement therapy, and that is, of course, with estrogen. So, early menarche, late menopause, nulliparity, first full-term pregnancy after 35, and exogenous intake of estrogen are all risk factors, increased estrogen exposure. Early menopause means she stopped seeing her period earlier. Late menarche means she started seeing her period later. So she had less periods if she had early menopause or late menarche. Multiparity means that she had less periods as well, because she would have had times where she was pregnant and for 9 months she would have not seen a period. First full-term pregnancy, earlier age, of course, same thing applies as to multiparity. So do not be confused by the early menarche, late menopause thing. It's early menarche means she had more periods. Late menopause means she had more periods. Nulliparity means she had more periods. First full-term pregnancy, advanced maternal age, more periods. And of course, hormonal replacement therapy is a big one. Okay? So that's one way that they love to bring this question, and don't be tricked by it. I'm pleased that most of you all got it correct. Of course, you need to know that cancers are a risk for breast cancer. And what are the cancers? Well, obviously, if you had breast cancer in one breast, she's at risk of breast cancer in the other breast. A history of ovarian, endometrial, and colorectal cancer. Ovarian and endometrial are also estrogen dependent. And so that's why once you know the risk factors for breast cancer in terms of estrogen exposure, you know the risk factors for endometrial and ovarian, because they are all estrogen sensitive types of cancers. So a history of ovarian, history of endometrial cancer is high yield, and a history of colorectal cancer as well increases a patient's risk of breast cancer. And when we do CRC, we'll see why that is so when we talk about all the different syndromes and so on associated with colorectal cancer, right? So it's ovarian, endometrial, colorectal as the cancers, and of course, a history of breast cancer, right? Estrogen exposure, early menarche, late menopause, nulliparity, first full-term pregnancy after 35, and HRT. Next would be critical to know are the main genetic conditions, that is BRCA1 and BRCA2, Li-Fraumeni, and Peutz-Jeghers syndrome. Can anyone tell me what are the features of Peutz-Jeghers syndrome? And what is the gene that is mutated? No? Right? Okay, so I want you to be very specific with that, Brianna. So it is hematomatous polyps. That's great, right? And what else? Right, so mucosal hyperpigmentation, right? Fantastic. So it's hematomatous polyps. I spelled hemata wrong. It's Hemerta. Hematomatous polyps and mucosal hyperpigmentation. So that is hyperpigmentation of the mouth along with hematomatous polyps. And the gene affected there is the STK11 gene, or SKT. I think it's STK. Let me just double check that there, because I always mix up my, dyslexia that's kicking into play sometimes. Let's see. STK 11G one or SKT? I see, that's not. Oh yeah, it's STK. Nice. Good. So that's critically important to know as well, alright guys? So you could write that down. Because you'll see Peutz syndrome again when we do CRC. I go more into these syndromes when we do CRC. Leaf-Romany syndrome is where the patient has a risk of sarcoma, breast, leukemia, and adrenal glands. So it's SBLA. That's Leaf-Romany syndrome. And of course, we know BRCA1 and BRCA2. A family history of breast cancer is a strong risk factor, such that I remember Mr. Murad's teaching us specifically. If a patient comes in with a, let's say, fibroadenoma type picture, it's a young female, but she has a family history of breast cancer, in those patients, we are going to remove the lump for one reason or the other. The reasons being, one, for her own peace of mind. The other reason being that she has a strong history of breast cancer. So you want to take out that lump at this early age. So if she develops a lump at a later age, then you know that your clinical suspicions are high. So that's a common MCQ. A young female with a fibroadenoma, do you take out that breast mouse? And the answer is yes, mostly for her peace of mind, but also such that you don't mix up, or you don't, how to say, if she gets older, her risk of breast cancer is high, and you want to make sure that she had no lumps before to help to confuse you, right? So that's one question. Fibroadenoma in a young female with a family history of breast cancer, take it out. All right, good. Previous radiation to the chest wall, of course, is a risk factor, and certain lifestyle factors. Obesity having a high role to play, especially in postmenopausal women. And we'll see when we get to that question that a lot of you all chose the wrong answer as to why we use anastrozole in our postmenopausal ladies with hormone receptor positive breast cancer. Okay, so obesity is a risk factor, high fat diet, same kind of reason as obesity, and tobacco smoke is now correlated with breast cancer. Alcohol too, right? But that's lower yield on the scale. So about OCPs. If you have OCPs as a risk factor for breast cancer, you do not select it. Okay? There are other things, all of these things higher up, that are actually proven risk factors, evidence based. Oral contraceptive pills have what we call an unknown risk. All right. So, given that you see oral contraceptives as which of these is a risk factor, look at the other answers before you select that one. Okay, because that's unlikely to be the answer as a risk factor for breast cancer. The risk is quote unquote unknown. All right. So those are the most important risk factors. Learn them well, store them in your mind, and never ever forget them. Now there is this one risk factor that I've seen pop up in newer questions, not in MBBS, but in newer questions. That is this theory about night shift workers, right? So in night shift workers, they have high levels or high peaks of estrogen at different times throughout the day. And it has been found that a woman's estrogen peaks when she's awake at around 2 o'clock in the morning. So this is actually an evidence-based risk factor that night shift workers have a higher chance of breast cancer. So I've seen that in a USMLE type question. So I just thought I'd include it here just to be complete, right? Now, breastfeeding is protective. So, multi-parity, a woman gets more times she gives birth or more times she gets pregnant. Well, there's a difference between parity and all of that, right? But multi-parity and breastfeeding, just think, okay, this year is protective, right? So it is good to be a mother, at least where breast cancer is concerned. Not going to go into ethics and all of that kind of stuff, right? So that's the risk factors. That's a pretty okay list, pretty comprehensive. And those are the ones that I see pop up all the time. Biggest one is this increased estrogen exposure and mixing up early menarche, late menopause, and saying late menarche, early menopause, multi-parity. So they switch it around. Don't be tricked. Take your time, read the question, easy marks. Okay? So that's that for risk factors. So now let's talk a little bit about pathology, and I actually think that I will draw here, okay? Because I thought that this could probably be place that I could show. All right. So what's the most common pathological type of breast cancer overall, guys? They ask you what's the most common type of breast cancer pathology overall. Buddy? So it's invasive ductal carcinoma. Okay, fantastic. So invasive ductal carcinoma is the most common type overall. And what's the most common location for breast cancer in the breast? The upper outer quadrant. Fantastic, right? So invasive ductal carcinoma is the most common. It's responsible for about 80% of breast cancers. And that is a fact that you need to know. It could pop up. Now, you have invasive and in situ cancers. So let's do a little bit of drawing and stuff here. All right. So first we'll talk about the DCIS. So DCIS is ductal carcinoma in situ. So that's ductal carcinoma in situ, right? Then we have LCIS. That is lobular carcinoma in situ. Okay? So let's do DCIS first. So DCIS or ductal carcinoma in situ is indeed considered a breast cancer. Why is it considered a breast cancer? A ductal carcinoma in situ has a 25 to 60% chance of becoming invasive. Right? It has a 25 to 60% chance of becoming invasive and becoming invasive within 5 to 15 years. And so for that reason, a patient who has been diagnosed with a ductal carcinoma in situ, because of their risk of converting into an invasive carcinoma, these patients, we cut out the cancer, and the treatment of choice for DCIS is breast conservation surgery and radiotherapy. And we'll see breast conservation as wide local excision. Most commonly, sometimes it's just a lumpectomy. So for DCIS, your treatment of choice is breast conservation surgery. And of course, once you do BCS, you have to follow up with radiotherapy. In DCIS, there is no role for axillary lymph node dissection. ALND is what this means. Axillary lymph node dissection. There is no role. Why? It is in situ. So this is your breast here. This is, sorry, let's do it at a cellular level. This is the cellular level here. And this is the cancer here. In situ means it does not invade the basement membrane. So it is contained here. If it is in situ, it cannot spread to your lymphatics. It cannot spread hematogenously. It is contained. It has not yet crossed the basement membrane. And so for that reason, doing axillary clearance or anything to do with the lymph nodes, shit. Oh God, sorry. Right? Anything to do with the lymph nodes, no rule for ALND, right? That's what we had there, right? Makes no sense in DCIS. So we do not touch the lymph nodes if we have a DCIS, and we have no role for chemotherapy either. Why? Cancer doesn't spread, right? It's ductal carcinoma in situ. But because of the risk of this cancer now becoming invasive within 5 to 15 years at such a high chance, 25 to 60% of these patients will develop invasive carcinoma, ductal invasive carcinoma, then we have to take it out. We do have to treat it. Treatment of choice is breast conservation surgery and radiotherapy. So what about if the patient has a ductal carcinoma, but it's multifocal? And multifocal means many tumors or many sites of cancer within one quadrant. So this is one quadrant, and they have all of this one quadrant. This is multifocal. So in multifocal ductal carcinoma in situ, however, in these patients, they consider that you might leave back some micromets. So in these patients, we can opt not for an MRM, but a simple mastectomy. Okay, so if it's multifocal, we can do a simple mastectomy to mitigate our risk of micromets, but most times it's just going to be found in one quadrant and it's just going to be one tumor. And so for DCIS, we treat them with breast conservation surgery followed by radiotherapy. Okay, no lymph node touching, no chemotherapy for DCIS. All right, so we could erase that now. I don't know if you want to take a picture. It's very scrappy. I hope you wrote it down. But I think most of it is in the guide as well. Right? So, what about lobular carcinoma in situ now? So, lobular carcinoma in situ has now been removed. It is no longer considered truly breast cancer. So, LCIS is no longer considered breast cancer. Okay? Why is that? In patients with LCIS, they have only a 5 to 15% risk of becoming invasive. And what type of cancer does LCIS become? It too has a greater chance of becoming invasive ductal rather than invasive lobular, right? So yes, it is lobular in situ, but it still has a greater chance of converting or transforming or progressing to invasive ductal. But it's only a 5 to 15% risk. And also the time it takes to get to this risk is about 15 to 25 years. So we have a risk of 15 to 25 years, 5 to 15% of these patients will get cancer. The other concept is that these patients tend to be diagnosed at the perimenopausal age. Perimenopausal, let's say that woman is 50 years old. For lobular carcinoma in situ, because the risk is so low and because the time that it takes is so high, then we do not need to operate. We do not, no operator, no, I have a brethren who they say, can't operate. We can't operate. That's how them surgeons just talk. We can't operate. No operator, no operation for LCIS. All right? Because, well, this woman is likely to be perimenopausal. If she is to develop invasive ductal carcinoma, she'll probably be 75 years of age. And the teaching point here is in oncological surgery or surgical oncology. Our goal is to prolong life expectancy if we are to operate. All right. But this woman is likely to be about this age to develop, if she does go on to develop cancer from an LCIS, if she does go on to develop an invasive cancer. So her life expectancy is already at the upper limit. And so by that age, 75 years old, whether she develops breast cancer or not, very morbid to say, but it's likely that some other comorbidity will also have a risk of causing her demise. And so in terms of resources and benefit versus risk stratification, in these patients with LCIS, because they are likely, if they do develop, they are unlikely in the first place, to develop invasive cancer. But if they do develop invasive cancer, they are most likely to be at the peak life expectancy already. We cannot operate, we should not operate, we ought not to operate on them because this was no longer prolong their life expectancy. It will be considered a waste of resources. And so for LCIS, the takeaway point is it's not a cancer, not considered cancer for this reason. We do not operate for the most part, right? For the most part, of course, everything is different. So what do we do? Instead, we do what we call active surveillance. And you see this word come up again in prostate cancer. We do active surveillance, and our investigation of choice would be an MRI to see if at any point this cancer seems to be becoming more and more malignant. All right? We can also do, for LCIS, I'm going to put it here, we can also do something called chemoprevention. And that's where we give them prophylactic, basically, hormone receptor therapy, right? Things like tamoxifen, prophylactic tamoxifen or prophylactic anostrozole, concerning whether or not she is hormone receptor positive in the first place, right? Because the only way to diagnose LCIS would be to do a biopsy, and we'll have to do a core biopsy to make sure, and we will get the receptor status there, right? So we can do chemoprevention in LCIS patients if they are hormone receptor positive, but for the most part, we do not operate. It's not a cancer. We do active surveillance with MRI for LCIS. All right? So that's the first time I've ever actually written or anything. I usually just talk surgery, but I think if you see it, you kind of remember. Okay? So are we clear about those concepts of LCIS and DCIS, guys? We know how we manage in a DCIS now and so on. Are we clear? Any questions on that concept? All right. Fantastic. Okay. Great. So I think you all unanimously got one of those questions wrong. I think it was the DCIS treatment. Right, so everything should be here in a roundabout way. Let's see. Ductal carcinoma in situ, we just said high risk of invasive ductal treatment is surgical for the DCIS because there's a high risk of converting into invasive ductal. But our treatment would be breast conservation surgery and radiotherapy. If it is multifocal, we can opt for a simple mastectomy. We do not touch the lymph nodes, so it's never MRM for DCIS, right? We never taken out lymph nodes, we never do a lymph node biopsy. It is contained, it does not cross the basement membrane, it does not spread to the lymph nodes, so there's no rule for actually lymph node dissection. There's also no rule for chemotherapy for the very same reason. For lobular carcinoma in situ, we just said LCIS, they have this low chance of becoming cancerous. Even if they do become cancerous, the patient is likely to already reach her life expectancy. So we don't need to necessarily remove or do a surgery for LCIS. All right, that's against evidence-based medicine. And so what we do is active surveillance with MRI. All right, chemoprevention can also be used with our hormone therapy. Good. So invasive carcinomas, invasive ductal, we said is the most common. Unfortunately, it's the most common and the most aggressive. I shouldn't say most aggressive. That's a lie. Because my question to you is, which type of cancer, which pathological type of cancer has the worst prognosis? Answers in the chat. That could be another question. Although it's probably unlikely. Fantastic, Celine, right? So inflammatory. Well done, Christina. So inflammatory breast cancer has the worst prognosis. But out of the two, between ductal and lobular, because those are the two most common, by far ductal is more common. It is overall the most common type. It is aggressive. It metastasizes early. It's unilateral. And most of the time, it's also unifocal. Compare that to invasive lobular. It's less aggressive with slower mets. It tends to be bilateral, and I should also put here LCIS also tends to be bilateral as well, right? And that's another reason we don't operate on LCIS, because if it's bilateral, then we'll have to cut out both of the woman breasts, right? Or operate on both her breasts. And again, benefits risk, that whole evidence-based explanation, which you all grasp, right? But an invasive lobular carcinoma is also commonly bilateral and multifocal. Okay, so learn these little things, these little tidbits about ductal being aggressive with early mets and unilateral, because they could ask you a fact-based, which of the following is true concerning invasive ductal, or some form of fashion in your MCQs. They can ask you these little tidbits that you might otherwise take for granted. So don't take anything I have on these slides or anything I say in class for granted. Learn it all. All right. We have other subtypes, of course: mucinous, medullary, tubular, inflammatory, and we said inflammatory has the worst prognosis. So that's the pathological thing. Yes, it is tested. Learn it well. Risk factors tested. Learn it very well. So what about our workup now of our breast cancer? So this is, how to put it, in real life, in Viva, anywhere on the wards, anytime you are a medical student, you need to know all of the features of a breast mass that is suspicious for breast cancer. All right. So when we're doing breast cancer workup, what is important is we take a thorough history and exam. We have to take a thorough history to explore all of this patient's risk factors. Does she have a family history? Does she have early menarche, late menopause? Does she nulliparous? Has she ever had children? Was her first pregnancy after the age of 35? All of these things we have to elicit. And in a real life setting, working with Mr. Ravi Maraj, who is a breast, he actually specialized in breast and specialized in surgical oncology. That was such a fantastic experience. Kudos to surgery, kudos to Mr. Ravi and Ms. Ramprasad and all of my surgeons. They're not here, but I have to give them their glory because that's why I can teach this. But when those patients with breast cancer came in, with breast masses came in, and if they had any inkling of a high risk, it used to be paid. These patients got a lot of care and rapid workup, because something as simple as having a family history, something as simple as she never gave birth. She was nulliparous. Something as simple as she started seeing her period when she was 7. Something as simple as she didn't see menopause till she was 58. Those things actually alter your approach to them, right? So your history is important, knowing your risk factors, etc., is critically important, and that's why it's so commonly tested. It does alter the surgeon's decision. All right. So when you take a history and you do your exam, patient is likely to tell you they have a mass. They may tell you they have a discharge, and they may tell you about some skin changes. Less commonly would be something like mastalgia. Yes, some breast cancers are painful, but that is more seen in ulcerative growths or inflammatory breast cancer, right? So for all intents and purposes, we're looking at the features of our mass, our discharge, and the skin changes we ought to see and make us think breast cancer. So the mass of breast cancer is hard, ill-defined. It is a non-tender mass. It's what we call craggy, and it's low mobility and bosselated. All of these features of a mass make this mass more likely to be cancerous in any part of the body. Any hard, ill-defined mass that is non-tender, it just pop out anywhere. It's very irregular. It's bosselated. It's fixed. Those things are suspicious for cancer anywhere in the body. Better as well biopsy that mass. Okay, that's the feature of a mass. First question, guys. Bloody discharge. Bloody discharge. Oh, bloody hell, a bloody discharge from the breast. Everyone chose intraductal papilloma. Not everyone. some of you all actually chose breast cancer. What makes a bloody discharge more likely to be cancer? Well, first and foremost, the most common cause of a bloody breast discharge, yes, it is an intraductal papilloma. So you could write that down. Intraductal papilloma is indeed the most common cause of a bloody discharge. However, if cancer is to have a discharge, it is most common that that discharge will be bloody. So if a patient has a breast cancer and they do have a discharge, it is likely that that discharge will be bloody. So what makes you think that this bloody discharge is due to cancer? One, it's associated with a palpable mass as described above. Two, the discharge is spontaneous, meaning she does not have to manipulate the breast or squeeze the nipple for the discharge to come out. It spontaneously happens. Three, the discharge comes from a single duct. A single duct that makes the discharge more likely to be cancerous, the bloody discharge. And four, she has discharge coming out of one breast, unilateral. So well, of course, her entire history, right? But in terms of the discharge itself, Anton is funny. Chiola self. In terms of the discharge itself, what makes the bloody discharge more likely to be cancerous? It's spontaneous, it's unilateral, it comes from a single duct, and it's associated with a suspicious mass. So you need to know those features of a bloody discharge because that helps you narrow down, A, is this an intraductal papilloma, which is overall more common and more likely? Or in this patient that I am looking at, is this a cancer? Because this bloody discharge is spontaneous. It's unilateral. It comes out from a single duct and then she has this mass. And as Anton says, she's old as hell too. All right? So look at that in your question stem. Okay? So look out for that. That's a trick. Good. Next features on exam and of course in the history would be skin changes. And the skin changes that we have to take note of would be skin dimpling, skin puckering, skin tethering. I'm not going into the pathology as to why they happen. Is it tested as to why it happens? I think if any of it is to be tested as to why you have those skin changes, it will be this one, pure orange, right? So in pure orange, what you have is the cancer obstructs the subepidermal lymphatics. So learn this exact phrase. So the cancer obstructs the subepidermal lymphatics. So what that leads to is lymphedema. So the lymphedema causes the skin to swell, but because the lymphatics are obstructed, but the hair follicles are not, your hair follicles don't swell. And so that pure orange or orange peel appearance is due to the hair follicles not swelling, but the skin swelling, the lymphedema. So it's because of subepidermal lymphatic obstruction that leads to purulence. And when we get to staging, we realize that if our patient presents with purulence, she's automatically considered T4. Okay, so when we get to staging, we'll stress on that a little more. But these are the features that are, or history and exam features that are suspicious. Was purulent, would we then consider ductal ectasia instead? Well, a purulent discharge depends on an entire picture, okay, Anton? So purulent could be something like an abscess as well. Ductal ectasia can be purulent as well, but it's more commonly due to infection. Pus suggests inflammation and infection, okay? So, but it depends on the entire history. I think I have lowered down the causes of the different types of discharge, right? But ductal ectasia is usually a green discharge, just to clarify that for you, okay? So if you see green discharge, then you think duct ectasia. If they tell you green discharge, just know that it's duct ectasia. Don't think too hard about it. Good? Right? Guys, are we clear on this discharge thing? Because I think a lot of you all had gotten that question, no? We clear on the features suspicious for breast cancer. Yeah? Fantastic. Great. So exam findings, of course, we should know how to perform a breast exam. We are year 5 medical students. So the breast could be asymmetry, you know, we start off with their hands on the legs, and then they raise their hands, to stretch out their hands, to kind of clench the pecs muscle, and all of those, you know how to do a breast exam, right? But of course, if the breast seems asymmetrical, skin changes, all the other things, we know that. Do not forget in your breast exam, it is critically important to palpate the axilla for axillary lymph nodes. And we'll see why and how critically important it is to palpate your axilla in a patient who you're doing a breast exam. Okay? Good. So that's history and exam. So what's the other part of this triple assessment? So we did history and exam. This is not imagine. Imagine is verb. This is supposed to be imaging, which is a noun. Okay. Our next step would be our imaging, which is radiology. So there are 3 main modalities of investigating image-wise of radiological investigations that are used in breast cancer. 1, ultrasound. 2, mammogram. 3, MRI. They all have different indications for use. We should know that ultrasound is preferred in younger women, denser breasts. So yeah, all you chose ultrasound, I think unanimously. I think everyone had chosen ultrasound for our 27-year-old came in with this breast mass. So hold that thought, okay? Ultrasound preferred in younger women. It is used to differentiate between cysts and solid lumps, and therefore in a dense breast, it's pretty useful. And of course, you can use ultrasound to guide any biopsy you have to do. So what are the features on an ultrasound that makes a mass likely to be malignancy, or more suspicious, I should say, for malignancy? That is, if the mass is hypoechoic, that suggests that it is a solid lump rather than a cyst. That cyst is fluid filled and tends to be anechoic. Cysts are anechoic on ultrasound. Hypoechoic means that the echo is bouncing off of a solid lump. And so solid lump suspicious for malignancy is hypoechoic. And of course, the same features we think about. Irregular margins. Also, if there's posterior acoustic shadowing, and if it is taller than it is wide. So write down all of those features for your ultrasound findings. That makes it more suspicious for a malignancy. Okay? So ultrasound is indeed preferred in younger women to investigate the breast and to image the breast, and women with denser breasts. All right? You all are correct. Now this big bad boy here, this mammogram thing. So your mammogram, when we're speaking about mammogram, we need to speak about screening to mammogram, and then what exactly is a diagnostic mammogram and what it entails. So yes, mammograms are used for screening of breast cancer. All right, that is correct. There are 2 views, the mediolateral oblique and the craniocaudal. And oftentimes when I had my viva, I don't think you'll actually have a viva. I got breast cancer for my viva, and they showed me this, and they asked me which one is the craniocaudal and which one is the mediolateral oblique. And so your MLO, your mediolateral oblique, you'll see this muscle here. All right? And so for your MLO, you could see the pec major, right? So you'll see this muscle in the medial lateral oblique. This is our craniocaudal view on our mammogram. Remember, a mammogram is X-rays review. Okay? So it is preferred in older women with less dense breasts, and it is a screening tool in most cases. But if on our BIRADS breast imaging reporting and data system, that is what we use to score our mammogram findings. If on BIRADS we have a BIRADS 5, that is considered a diagnostic mammogram. That means that we can say that with 95% certainty this patient has breast cancer. So what gives you a BIRADS 5 on mammogram? That is these exact words you need to learn here. Speculated margins, aka a stellate or star-like appearance, and clustered microcalcifications, guys. Not just microcalcifications, no other preceding adjective to describe the microcalcifications other than clustered. Clustered microcalcifications, speculated margins, a stellate appearance, that equates a BIRADS 5 on our mammogram. That is malignancy, that is a diagnostic mammogram. Okay? Just microcalcifications, diffuse microcalcifications, that is benign. So do not let them say microcalcifications and you now come and say, all right, it's a BIRADS. If they say diffuse, of course, it is benign. Excuse me, guys. Yeah, babe. Yeah. Right. Sorry, guys. Guys, give me 1 second, right? Not even 1 second. Give me like 2 minutes, right? I'm coming. Coming. Um, Yeah, my cluster microcalcification. Yeah, take note of that. That's critically important. I'll be back in 2 minutes. Take this as a little break. I'm coming. All right, sorry about that, guys. Apologies there. Uh, you'll find now bring some food for me. Get through in the life. Y'all hearing me, Anthony hearing me?
Yes, Doc, hearing you.
Cool. Yeah, so we starting back now, right? Yeah, sorry about that, guys. So as I was saying, make sure you know your diagnostic MMG as a BIRADS 5, okay? And look for these words. That is clustered microcalcifications, that is speculated margins or stellate appearance, okay? That makes it highly suspicious for malignancy, more than 95%. It's considered diagnostic. All right. So a benign lesion on mammogram is more likely to have diffuse or coarse microcalcifications. And of course, it's more likely to be well defined, circumscribed. And this halo sign is this radiolucent ring around the lesion. Okay. So you need to learn your BIRADS, guys. That's why I put it in the guide. You need to learn every part of it. One, two, three, four, five, six. Know what it means. Sorry. Zero, one, two, three, four, five, six, I should say, right? And of course, 4 is divided into 4A, B, and 4C. So know this, learn this off. It's self-explanatory. BIRADS is critical to know. All right, so that's our mammogram there. This is an image. This is actually cancer. This is actually clustered microcalcifications with speculated lesions. Okay, so this is a MLO and this is a craniotomy. All right. Um, Good. So, excuse me. Important concept is that most patients will have normal imaging. And so that's why in any woman who comes in with a breast mass, triple assessment is critical. Completing your triple assessment is critical. It's history and exam, it's imaging, not imaging, and it's of course assessing our pathology. So what about our path? No, 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 no. Sorry. Let me do MRI first, then we do our pathology. So before we go on to pathology, let me speak about MRI and this MRI thing. Forget this is, yeah, pathology is next. So the mammography and the ultrasound, usually we combine them in most patients, all right? Most patients with breast cancer, we combine ultrasound and mammography. Um, Most of the times, if they're older, we'll do both. If they're younger, we'll probably just do ultrasound. So what is this thing about MRI? What is this thing with MRI? Well, MRI has a very, very particular indication as a screening tool. MRI is the most appropriate screening tool in a patient less than 30 years old with a family history or known history of BRCA. So if you have a young patient with a high chance of a genetic abnormality that predisposes them to breast cancer, your screening tool of choice in that patient is MRI. And it's the screening tool of choice in young patients less than 30 with BRCA. Why? If you do a mammography or if you have any sort of radiation to that patient, their risk of converting to malignancy is increased. MRI is also used to look at very dense breasts. And so in more dense breasts, MRI can also be used in patients with breast cancer to rule out multicentricity. So we'll see going forward the contraindications to breast conservation surgery. One of them is multicentricity. Multicentricity means multiple lesions in multiple quadrants. Multifocality is multiple lesions in a single quadrant. Multicentricity, she has many tumors or many lesions throughout all or many more than one quadrant of the breast. And so MRI ought to be done because this is better at assessing or ruling out multicentricity in patients who we plan to do breast conservation surgery for. So if we do the MRI and we see multicentricity on it, because the mammography cannot tell us that, then we'll say, all right, we probably do a mastectomy in your case. All right. So the other thing is patients with breast implants is another category of or population of patients in whom we use MRI for screening. All right. And we could also use MRI post chemo and radiotherapy, chemo and hormonal therapy, we can use MRI to assess the response to therapy. All right. So in a young patient, strong history of BRCA, MRI as a screening tool. All right. Breast implants, MRI as a screening tool. And before she has a BCS, we want to do an MRI. Okay. So MRI, mammography, and ultrasound all have their particular role in breast cancer as part of our imaging. All right? And of course, to stage breast cancer is what we use CT scan for. The CT scan will look at our entire body, and we have to use CT chest, abdo-pelvis with IV contrast. All right? I want my Trinidadian students, especially if you work in Mount Hope, and the doc asks you to write uh, 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 um, a metastatic screen CT, you say, all right, screening for Mets, CT cap, number CT cap with IV contrast on your radiology form. Because I've had many interns just do CT cap with no IV contrast. And the radiology calling us and saying, right? So, anyways. So that's the imaging. So are we clear on the specific rules, the diagnostics of mammogram, the BIRADS? Also, guys, know what BIRAD stands for? Breast Imaging Reporting and Data System. I have seen this as an MCQ. What does BIRAD stand for? And it's Breast Imaging Reporting and Data System. And they actually kind of made up things that sound like it could be what BIRAD stand for. So make sure you know exactly what it stands for, right? Good. So that's imaging. And to complete triple assessment, before we take questions, let me just explain the pathology. So when we talk about triple assessment, we do history, exam, and imaging. Next thing is pathology. So history and exam, imaging must be followed by pathology to complete your triple assessment, because as we said, some lesions, especially in a mammography, 10% of patients, you will miss a lesion. All right? We have 5 options for our means of assessing and obtaining a sample to send to the lab. 2 most commonly used ones are FNAC and core biopsy. FNAC and core biopsy have very specific indications. And the first one we'll talk about is FNAC. Not just indications, but advantages. The benefits of a fine needle aspiration cytology, as the name suggests, you're going to take a fine needle and aspirate cells. The benefit of that is that you could do it in an office setting. It's quick, it is easy, and you could get results. You look under a microscope or wherever the labs do and get the results the same day. So therefore, FNAC has its place and its benefits, but it only assesses the cells and the cytology. Excuse me, sorry. Therefore, it cannot tell invasion of our basement membrane, and so FNAC cannot differentiate an in situ carcinoma from an invasive carcinoma. So in a patient, we're saying, all right, this patient unlikely to actually have a breast cancer, unlikely to have an invasive cancer. This patient probably have a little thyroadenoma or ductal papilloma or some kind of thing. Then you might say, all right, FNAC, we'll do it in the office, we'll do it quick, get your results one time, and then of course, you're good to go, right? So if they're not suspicious, they don't want a lumpectomy, you'll do a FNAC. But of course, by far, the superior investigation to do, and this applies, like, remember thyroid, guys, which thyroid cancer should we not use FNAC on? Pathology. Follicular, fantastic, because we cannot see crossing of the basement membrane. Because follicular adenoma versus follicular carcinoma, blah, blah, blah. Good. All right, we have a whole lecture on thyroid. Fantastic. So it's the same concept that applies to breast, because thyroid is kind of a triple assessment too, barring you have blood tests and so on. But when you get to thyroid, that's another story. The core biopsy is used for histology. So your core biopsy can tell invasion of the basement membrane, and therefore it can be used to differentiate between invasive and in situ. And so core biopsy is, of course, the superior investigation. So any patient who you suspect, you have a core biopsy to do. You do not do an FNAC in a patient who you suspect has breast cancer. All right, so any inkling of suspicion, you do a core biopsy. The limitation is that it's more complex, can be done in an office, you need a core, you need to take tissue, etc. So results are not immediate, you have to send it to what is called Barnyard in Mount Hope, send it to the lab and let them, do all of these assessments, and then you get back the results. So there is the time limitations, but you need to be sure. So any patient who's suspicious, you do a core biopsy. critical. What else can a core biopsy tell you guys? It can tell you the pathological type. It can tell you the receptor status. It can tell you the grade of the tumor. And can anyone tell me what else a core biopsy can tell you? You need to know all of this. So it tells the invasion of the basement membrane, helps to differentiate between invasive and in situ. It tells you pathological type. Is it ductal? Is it lobular? It tells you, is it ER, PR positive? Is it HER2 new positive? And it can give you the grade of the tumor as well. Can anyone tell me what else core biopsy can tell us? That's not the answer I'm looking for. The answer I'm looking for is Chi-67. Guys, pay attention here. So when you get this question, or if you get, see when, if you get this question, heard it here first. Prognosis. Best prognosis. Overall. The best prognosis is an invasive tubular cancer. Overall, that's the pathological type with the best prognosis. The worst, we said, worst prognosis was inflammatory. Then you have to think about prognosis based on our molecular markers. So let me erase this, write this down for you. So we have molecular markers, guys. That would be our hormone receptors, ER, PR, HER2 new, and Chi-67. This is a 6. Okay? So what could happen is it could be ER, PR positive with HER2 negative. We'll talk about Chi in a bit. Ki, that's Ki-67. You could be ERP positive, HER2 negative. And this Chi could be less than 15%. This is a 5, my gosh. Oh my goodness. Wow. This is unacceptable. This is unacceptable. Right. Less than 15%. You could have ER, PR positive, HER2 negative, Chi more than 15%. You could have ER, PR negative and HER2 positive. And you could have what some might say is triple negative, but it's not really. This is what we call the molecular markers, and how we categorize it is luminal type A. This is luminal type B. This is HER2 enriched. And this is basal. This is called the basal type. So basal type is different to triple negative. Basal type we use in cancers of myoepithelial origin. A lot of cancers are of myoepithelial origin. We use triple negative to describe cancers of ductal origin. It's just a semantics thing. But in terms of prognosis, guys, out of the molecular marker classifications, that is luminal type A, luminal type B, HER2 enriched, and basal type, the best prognosis is this one. Luminal type A, that gives us the best prognosis. Why? ERPR is positive, and so we have hormonal therapy, which is good. HER2 being positive, even though we have our trastuzumab, is not good. It's actually associated with a worse prognosis, even though we have. And very importantly, Chi-67, that pathological thing that you find, the last one you see on a core biopsy, the lower the percentage, the better the prognosis. And that is a particularly high yield point. So if the patient has a less than 15% Chi-67 horizon, ERPR positive, HER2 negative, this has the best prognosis out of all of our molecular markers, luminal type A. Whereas, if the patient had a 15 or more than 15%, this has a worse prognosis than if they had a Chi-67 of less than 15%. So the lower the percentage of Chi-67, the better the prognosis. The worst prognosis is here, basal type. Why? Well, you have no hormone receptors. And so therefore, you can't target, you can't do your anastrozole and tamoxifen and so on. So this actually has the worst prognosis. So the basal type has the worst prognosis. Luminal type A has the best. Luminal type B in between, as well as HER2 enriched being in between. All right. So y'all could probably take a picture of that. I know it's scrappy, but I hope that you all were paying attention and you could recreate your thing. My handwriting has been atrocious all of my life. So say I was kind of born to be a doctor or something like that. Well, I actually wasn't, eh? A real troublemaker back in my days, right? So is that concept clear, guys? And we know what we could see on a core biopsy as well, right? Fantastic. Good. So that's the difference between core, FNAC, and this is very important to know all the things that you can see on a core. So what about if you do you're working up this patient triple assessment, right? The patient's history and exam. History is suspicious for breast cancer, but when you examine them, you have no lump. But when you do a mammogram, you're seeing this kind of speculated appearance and microcalcifications. Which one are you going to do there? Which investigation? So a patient has a non-palpable mass that is seen on mammogram. That is the MCQ. What is your next step? It's non-palpable on exam. Sure. So wire localization or stereotactic biopsy. Fantastic, right? So these stereotactic and wire localization are used to biopsy a non-palpable lump. It's a commonly asked question. Do not get it wrong, please. They'll tell you the patient had a lump this year mammography, but the surgeon, when they was examining, didn't feel the lump. What's your next step? Your next step is to use a stereotactic or wire localization to biopsy. All right? Okay, watch a little YouTube video on how those things work. We're not going into that right now. A biopsy can also be open. This is less preferred. It's only really done if you don't get a adequate sample. All right, so we don't really do open biopsies at all. Hardly ever do. Okay. So we've diagnosed cancer. What's our next step, guys? For some reason, as a student, I always used to get this question wrong. I kid you not. Doc will say, "All right, we diagnosed cancer. What's the next step?" Staging. Thanks. All right. Thank you very much. Yeah. Staging, right? So we have to stage our cancer. So here's where we'll take our 5-minute break. We'll come back to staging and so on. Are we clear thus far, guys? We clear on the breast, we clear on the DCIS, we clear on indications for different investigations. We know what quarters show. We know about skin changes. We know bloody discharge. Yeah, it's intraductal, but it could be cancer. And we know why it's cancer. We know why LCIS is not cancer. Yada, yada, yada. Fantastic. All right, guys. So we'll start back at, you know, we take a 7-minute break. So we start back at 7:36. Okay? 7:36, and we'll come back to staging. All right, cool. Right. Hey everyone. Um, Doing good so far, I think. It's not too bad. Let's see. So we spoke to Aliyah times two. Spoke to Abigail. We spoke to Adil. We would have spoken to Keely. Okay. Alima?
Hey,
Alima, you know I'm not familiar with your voice and you've been with me before. Sing a song there. What is this? What song you like to sing?
not good.
Okay.
It's fine.
How's how these class? You were with me for the OSCE.
Yeah, I came for the Austrian. I think it was IM last year or whenever I had
Did I am?
IM.
December I am.
Yeah,
Okay. How that turned out? How was the course in terms of helping out with your end of clerkship?
honestly, it was quite helpful.
Okay. Like Ramla can sing and Sandy and then bring questions like based on what I thought.
Yeah, they did actually, especially the like causative organisms and all those things. They brought about word for word.
Yeah. So good marketing there, Halima. Good marketing.
Of
All right,
course.
cool. And how you find so you wouldn't have had surgery with me before, so how you find the surgery going so far?
No, I didn't do it before, but it's going well so far.
Okay, all right, cool. All right, Halima, well I know your voice now. Thanks. So I'll see you around. See you around. Halima was with me since last year, so I know Halima. So that's our St. Augustine. Let's see. Well, we always speak to Alicia, so we'll give Alicia a break today, because Alicia is my plug, my key for the plug. So we'll go to Amina. Amina or Amina?
Hey, good night, Amina.
Amina. Hi, Amina. You're okay, Phil. Good. How are you?
I'm okay. Um,
How class has been for you?
this is extremely helpful. It
Yeah.
also gives a sense of direction, like the other students would have mentioned.
Hmm. Okay. Nice. I know that Phil um can usually do with a little bit of more help, right? Nicely put. So I'm glad that you are benefiting. Okay, we leave it at that. You leave it at that. All right. Okay, so that was I mean, what's your last name? How you spell it? Because remember, I'd misspell it when I had WhatsApp you or something like that.
It's pronounced Meter, Mehter.
Where you from?
Barbados.
Okay, cool. All right, meter. All right. Thanks. Let's see. So that's our key, Phil. I know. Let me see. I'll confirm Mona here. Anton. Anton! Again.
Yes, Doc.
Is he seen by how these set of classes going for you?
It's good, Doc. I'm following, man. I'm just
Following
taking
along.
information. It's just really to get a chance to go over. So it's like repetitive. So that's what
Mm-hmm.
I'm doing. But yeah, it's good as usual.
Thanks. Okay. Fantastic. And how Kimberly going there?
She's doing great. She's stressed out, but she's good.
Yeah, she messaged me the other day. And she was like, she's remember things I see on the wall and stuff. I say, how the hell you remember them things I see on the wall and stuff? You know, better things to do than remember class homework.
Right?
All right, cool, man. So I know Anton from before and Miguel, come. Miguel. Well, if familiar, Miguel is my Bahamas plug. So the SCMR should know Miguel. Miguel, is there, boy? Miguel always partying. So I messaged this man to send Bahamas the link. It's the man birthday, he partying. Man come and reply to me about 2 years after. But he did a fantastic job at marketing to Bahamas. So Miguel isn't answering right now. So let's see if we have any more of the Bahamians. I think I had one more. Um Wellington, you from Bahamas?
Yeah.
Yeah, and
It's
yeah.
going good.
Okay, great. Right. I didn't see a campus next to your name, but you're from Bahamas. All right, cool. Right, nice. All right, everyone. So thanks for that. I like to hear you all speak and know your voices and stuff. And if ever you all see me in person, that is from any region. If I go and take my Grand Hyatt Bahama in Bahamas, or I go to Sandals or something in Jamaica. I don't know what's a nice place in Barbados. I have been to Barbados, but I don't know any nice places. I went to in Barbados. I went to the Harrison's Cave and I went on a submarine and stuff as a teenager. And I know I'll never go back on a submarine again. So that some things you only do once, right? So thanks everyone for interacting with me. It keeps me awake, and we will now finish up breast cancer um staging and treatment and so. Okay, cool. Right guys, so back to work. So staging. So in your guide, you're gonna see this picture. Now this picture is from the Principles and Practice of Surgery edited by O. James Garden. Um, did I ever actually read Principles and Practice, the study for surgery? Probably never in my life. But when I was making class, I gave it a glance through and I just found that it wasn't particularly helpful for exams. Not to knock the book, of course, it's a fantastic book, but for MBBS, not so much. And one of the reasons was these kinds of things, unless there is an updated version, I probably do not have the updated version, so forgive me. But like this staging is no longer the staging that you're going to use, guys. For our staging of breast cancer, we are going to use the AJCC 8 guidelines. Okay? So pay strict attention here, everyone. I'm going to point out to you, yes, you need to know the entire staging system, right? You need to know every single aspect of the staging system. You have to know it. But I'm going to point out to you particularly what is important to take note of. One, this staging here includes in your TIS lobular carcinoma in situ. So back then, lobular carcinoma was still a cancer. This staging is no longer relevant because lobular carcinoma, we just said, is not a cancer. Someone just joined and they unmuted. Right. So for this staging, that is our AGCC TNM staging of breast cancer, we have Tx as the tumor cannot be assessed and T0 as no evidence. There is no LCIS. It starts at T in situ, that is ductal and Paget's disease. So your TIS in your TNM staging is ductal carcinoma in situ and Paget's disease of the nipple. That is not associated with an invasive carcinoma. It is simply Paget's disease of the nipple. Next, our T1, we do not necessarily need to know the exact millimeters, but we need to know it's less than 2 centimeters. T2 in terms of size, so T is tumor size, as we should know. T is between 2 to 5. T3 is more than 5 centimeters. And what I want to point out to you all here is T4. So T4 has certain, or I should say there are certain things that will automatically make a tumor T4. Because a T4 is any size with direct extension to the chest wall and or to the skin. Extension to the chest wall, however, does not mean extension to the pec muscle. So it extension to the chest wall, not including the pec muscle. So if they tell you the cancer extends to the pec muscle in your question, that is not T4. They need to tell you it's extension to the chest wall, that is T4A. T4B is if the patient has ulceration, if they have an ipsilateral macroscopic satellite nodule, which you're not going to see in the MCQs. What you can see in the MCQs, apart from ulceration, is if the patient has edema, and we just said obstruction of the lymphatics, leading to swelling of the skin. That lymphodematous obstruction is called pure d'orange. So pure d'orange is T4B regardless of the size of the tumor. Ulceration is T4B regardless of the size of the tumor. Extension to the chest wall is T4A. except for pectoralis muscle. T4C is T4A and B combined. And of course, inflammatory breast cancer is T4D. So you need to know the T4s very, very well. You need to know that the in situs no longer include LCIS. They are just ductal and Pagets. And well, 1 is less than 2, T2 is 2 to 5, and T3 is more than 5 centimeters. So that's how we interpret that. That is critical to note. Now we have our clinical assessment. And for this clinical and for our pathological, I'd want you all to read through and you'd recognize that the clinical is the level at which we palpate the lymph nodes, and the pathological has to do with how many lymph nodes we can say the cancer has spread to. So you're going to read through that. And of course, M is whether or not you have Mets. All right, so I'm going to draw it out for you, a simplified version of your staging, and this is the AGCC 8th guidelines. So we have TIS, right? And we said the TIS, LCIS, no LCIS, right? It's not a cancer anymore. So let's erase our LCIS. Yeah, right? So I just did that so you all would know. So it's not LCIS, TIS would be, no. Oh my gosh. It's a lot. Oh God. Guys, bear with me. Size this thing is I think it's 5. Okay. Yeah, so we have DCIS and we have Pagets. So that's our T, right? Pagets, the apostrophe comes before the S, of course. So TIS, we have T1, T2, T3, T4. Of course, before we have TX and we have T0 is no cancer. TX is cannot assess. So T1 is less than 2. T2 is 2 to 5. T3 is more than 5. And T4, I told you all the ones to remember, T4A, which is chest wall, but no pec. T4B is pure orange and ulceration. T4C is A and B, makes it very easy. And T4D, we said, is inflammatory. Okay? So that's how easy it is to remember T staging. All right? So that's our T. Now I want you all to pay attention here because you'll see a lot of words and it looks very intimidating to read if you're talking about the clinical N, right? The clinical node status. So what I want you all to know is N1 is freely mobile. N1 is freely mobile and it is level 1, level 2 axillary lymph nodes. Okay? Level 1 and level 2 axillary lymph nodes freely mobile. N2 has a N2A and a N2B. So N2A is no longer freely mobile, it becomes fixed, but it's still level 1 and level 2. And N2B is where you have ipsilateral internal mammary. This is critical to note. Why? Your internal mammary lymph nodes are not usually palpable on exam. So you'll probably see this on imaging. So N2A, fixed level 1 and level 2. N2B is ipsilateral internal mammary. N3 now has a N3A, 3B, 3C. So 3A is, oh, I remember 3A is the first that involves level 3. So it's ipsilateral level 3 axillary lymph nodes. And that would be, okay, what is your level 3 lymph nodes? Okay, question is, what muscle divides the axilla in terms of the level of the lymph nodes? Pec minor. So you have lateral, medial, and deep 2. So lateral to the pec minor is level, which level? 1. Deep 2 is level 2. And medial is? Right. So fantastic. So pec minor separates the axilla, so you have level 1, level 2, level 3. Level 1 is lymph nodes lateral to the pec minor. Level 2 is deep or posterior to the pec minor. And level 3 is medial and even superior to the pec minor. So I remember superior because it includes your infraclavicular lymph nodes, which is inferior to the clavicle but superior to the pec major, if you think about it. So IPS3A is ipsilateral level 3 lymph nodes, which is the infraclavicular. And 3B is internal mammary, again, but is also the axillary lymph nodes. And N3C is for, I think it's N3C is ipsilateral supraclavicular, right? So instead of looking at, I know the words just look kind of long when you're reading it on your when you're actually reading it all together. Okay, so that's just to simplify it. You need to know the clinical and you need to know the pathological. So in terms of the pathological, N1 is 1 to 3 lymph nodes, N2 is 4 to 9, and N3. Oh, remember N3 is if you open both your palms, right? You'll have 10 fingers up, and if you play that you're squeezing a breast, that's how it will be N3. Yes, it's a rude way of remembering it, but I never forgot when my house officer taught me N3 is 10. All right, so that's the pathological in terms of the number of lymph nodes, but you need to know the clinical as well, the level, the mobility, and whether or not it's infraclavicular or supraclavicular. All right, so you need to know everything about the staging of breast cancer, the TNM staging, and the correlations between them. We know about T's 3 and 4. Seen a message here. What is N3B? N3B, oh, my handwriting, sorry. N3B is the ipsilateral, oh my gosh, worse, internal mammary, that's MAMM, as well as axillary lymph nodes, that's ALN. Right, so this is ipsilateral. Lord Father. Okay, so if you just want to clarify anything, just go here and you Google AGCC TNM staging of breast cancer. All right, so you need to know all of it. I just wrote it out for you all because I know how the words look on this thing. It looks kind of intimidating, but it actually is very easy. All right, so that's the TNM staging, and well, M of course would be mixed. So we need to know all the features of our TNM staging. And points to note was LCIS is no longer considered cancer. And 2B was the ipsilateral internal mammary lymph nodes. Right, guys? So it's all here. It's all here. It's all here. It's all in this thing. AJCC 8 guidelines. So what's N2B here? Ipsilateral internal mammary lymph nodes and absence of level 1 and 2 axillary lymph nodes. And 3B is right here, ipsilateral internal mammary plus the axillary lymph nodes. So notice the difference. So N2B is the internal mammary lymph nodes only, and N3B is internal mammary plus the axillary lymph nodes. Okay? Yeah? Good. Oh. Right. So that is that. Good, N0, N1, we did the pathological stage in there. Right. Good. So we just have to implant in our minds what the staging is. I'm seeing messages in my WhatsApp, sorry. Okay, Sarah is sharing it. Thank you so much. Yeah, thanks a lot. It was just on Google. I was too lazy to include it in my guide. Sorry about that, Florence. Yeah. Cool. So now we need to know what are we going to do when we stage our cancer. And to conclude the breast cancer aspect of it. Right, good. Right, this is my favorite part to teach. That is, right, so we're almost done. Nice. Good on time. That is the treatment of breast cancer. Right? Now, breast cancer, I'm doing it the way that Ravi Miraj, Mr. Ravi Miraj would have taught me, right? But just for general knowledge, just know that the reason I'm doing like how Dr. Miraj taught it at the point in time was because, well, he wrote the book, right? But just know we also have EBC, which is early breast cancer, right? And early breast cancer means T1 to T2. It means N0 to N1. And of course, no Mets, M0. We also have locally advanced breast cancer, which is T4, N0, M0, and T3, N1, M0. All right. As well as NET, which are N2 to 3 and M0, right? And then advanced breast cancer, ABC, advanced breast cancer is METS. So there is this gray area of T3, N0, M0, right? Because notice this is what local is, this is what early is. So is it local? Is it early? T3, N0, M0. So the teaching is it early? Is it locally advanced? What do we do? And so we treat T3, N0, M0 according to the locally advanced breast cancer guide as locally advanced breast cancer, according to this teaching, this mode of teaching it. All right, so there were two ways I learned it, and I'm very confused, but I'm going to teach it the way that Mr. Miraj taught it, right? So locally advanced means that we usually give neoadjuvant. We'll give neoadjuvant, then we'll do MRM, and then we'll do adjuvant therapy, right? So anyways, but let's watch it off for the guide. So for breast cancer, we have to think about it as being operable at presentation or inoperable at presentation, or is it metastatic? And that's how we taught it. He didn't teach it as early and locally advanced, all right? So I'm teaching it how he taught it to us. So T1 to 3 with an N0 to 1 and an M0, we will do surgery first and then adjuvant therapy. With the larger tumors, or any T4 that is, we will do T4 N to 2 or N to 3. We will do neoadjuvant therapy to downstage or downgrade or downsize, or in other words, make the tumor more operable. And then we will do surgery and then, of course, the necessary adjuvant therapy. And for metastatic disease, we will do palliative therapy. And I will speak a little bit about a very important question that comes up with metastatic breast cancer. So just kind of learn off this way. For the most part, if you learn it the early breast cancer way, this would apply. We'll do breast conservation plus radiotherapy or MRM plus adjuvant. If it is locally advanced breast cancer, well, then we would do neoadjuvant therapy to make it operable and like that, right? But the kind of gray area of a T3 N0, M0, we will do neoadjuvant therapy for that according to the locally advanced breast cancer classification way. Whereas in his teaching, if we had a T3 N0, M0, we would have not given neoadjuvant therapy. All right, so I think it's more of a surgeon preference thing, and so I teach it how we taught it as well. He's the guy, right? So just learn it like this. So if you see a stage T1 to 3 and 0 to 1 M0, we can offer either breast conservation or MRM. So let's talk a little bit about the surgical options. So you all are going to learn this off and stage it and treat accordingly. All right, and remember, T4 is inflammatory breast cancer. So inflammatory breast cancer, though it is small, though it may not be palpable, we have to downstage with neoadjuvant therapy first. Any T4 that is, any T4 makes it locally advanced, regardless of if it's the size. Remember what T4 is. So we have to do neoadjuvant therapy first and then treat. All right, so let's look at breast conservation surgery and what they test about it. So breast conservation surgery includes wide local excision, sentinel node biopsy, or axillary clearance. Now this is BCT to be specific, breast conservation. I forget what the T stands for. When you do the lymph node clearance, it's called BCT. Breast conservation surgery is just a lumpectomy or wide local excision without accessing the lymph nodes. But for all intents and purposes, we are talking about when a patient has one of these stages of cancer, T1 to 3 and 0 to 1 M0, this is what we will do. We will do a wide local excision And according to, we'll either do axillary clearance or sentinel lymph node biopsy, and I'll differentiate between the two, right? Now, the thing about breast conservation surgery is that it has to be followed by radiotherapy. Why adjuvant radiotherapy? Because the patient may have this, what we call micromets. You may have not removed all of the cancer, then they have microscopic remains and it metastasizes, and your whole surgery was to no avail. So, for breast conservation surgery, there are certain indications, or I should say, certain contraindications. And how they phrase this question is contraindications to breast conservation surgery. So, whatever are your contraindications to breast conservation surgery are your indications for mastectomy. It means that you cannot do breast conservation. It means you have to cut out the breast, right? So contraindications to breast conservation surgery is the same way as saying indications for mastectomy. Of course, in these patients who are operable at presentation. And those contraindications to breast conservation surgery, those indications for mastectomy are one, patient choice. So usually it would be some kind of old lady who, she lived her life already, make all her children. Does not necessarily, guys, give me 1 second, please. Give me 1 second, please. Alright, sorry about that. I just went to battle with our roach there. I have no idea where our roach came from. Alright. The woes of tonight's PNP. So, as I was saying, for breast conservation surgery, patient choice. So it will be an old lady, she doesn't necessarily care about the aesthetics of having a breast. Now, of course, a woman losing her breast is a very traumatic experience. But in elderly women, this might not be as traumatic, and they might just say, Doc, I need the breast no more, I don't make my children, just take it out. So patient choice can be a relative contraindication. Multicentricity, we said before, multicentricity, that is cancer in different quadrants, is a contraindication to breast conservation. And we said, therefore, we need to do MRI before we actually go and do breast conservation surgery. Next, the tumor location. So if it is below the nipple areola complex, then you will have to destroy the nipple areola complex. And destroying the nipple areola complex does not preserve the woman's aesthetics, right? So therefore, just take out the breast and finish. So tumor location. Tumor size is a relative contraindication because, so usually we would say a tumor size of more than 5 centimeters, we would opt for a mastectomy. But remember, we can do neoadjuvant therapy and downsize the tumor. So it is not an absolute. If we downsize it and say we get down to like 3 centimeters or whatever, then the patient could say, all right, doc, I prefer breast conservation surgery now. It's a relative contraindication. Pregnancy is an absolute contraindication. However, what you can do in some instances is deliver the baby early. The reason pregnancy is an absolute contraindication is why? Because it needs to be followed by radiotherapy. Cannot do radiotherapy in a pregnant woman. Gonna mash up the child. Okay? So pregnancy is an absolute contraindication. However, there are ways we can work around that if necessary or if the patient so decides. And of course, breast conservation surgery must be followed by radiotherapy. And so if you have a contraindication to radiotherapy, then you cannot do breast conservation surgery. Some of these include collagen vascular and connective tissue diseases. Lack of access to radiotherapy is actually a very, very important point. So when you offer patients breast conservation, you need to make sure, A, you have the transport to get